My name is Alyssa Brooke Williams. I remember I bought a book and I looked it over and I was like, oh wow, I do all 9 of these things. I did call a psychologist, and I spent time talking to a psychologist who then referred me to a psychiatrist, and together, through talking about, with them talking about what I talked about, they diagnosed me with BPD.
BPD is a psychiatric illness affecting many young adults. Psychiatric disorders are rare in and of themselves, but the most common type of personality disorder, and the one that will most often be encountered by teachers working in general education, is BPD. Therefore, it's important for educators to know the background on the disorder and what adaptations and treatments are available for students. This way, such options can be incorporated in the student's IEP so they may receive instructional support and special education services in certain areas. BPD is commonly misunderstood, and neglect of early diagnosis can result in damaging consequences later in the student's life. So the essential features include a pattern of impulsivity and instability in behaviors and interpersonal relationships, and especially self-image. The pattern is present by early adulthood and occurs across a variety of situations and contexts. Other symptoms usually include intense fear of abandonment, intense anger, and irritability. It is recognized by the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, as a pervasive disorder, enduring and flexible pattern of maladaptive inner experiences and pathological behaviors. There is a general reluctance to diagnose personality disorders before adolescence and early adulthood. Usually, if they were to diagnose something, it would be something on a lower end of the autism spectrum disorder coupled with a lower behavioral disorder such as generalized anxiety or manic depression. However, some emphasize that without early treatment, symptoms may worsen, which can greatly affect the integrity of one's life. It is very strange to draw lines between these disorders, or even drawing lines between psychology and psychiatry. But if you look on the psychosis spectrum, on the very highest end you have schizophrenia, and on the lower end you have borderline personality disorder. The reason BPD is even on the spectrum in the first place is because one of the most reoccurring symptoms involves not being able to separate delusional or perceived thinking from realistic or healthy coping mechanisms or certain patterns of thinking that fall along that line. That's why it's incredibly difficult for people to achieve certain things with this disorder, because they can't tell if what they're thinking is real or not. Just like a person with schizophrenia can't tell if the birds are talking to them or not, but to them it seems completely real. So it's like one of the most realistic dreams you've ever had. But for people with BPD, it's a pattern of thinking. And that pattern of thinking they cannot control. It's impossible for them to. Coupled with genetic and biological factors, brain chemical balance, and societal and environmental factors that could trigger that predisposition if they already have the genetic predisposition for the disorder in the first place. It can also coexist with other mental illnesses that the National Comorbidity Survey replication says the largest national study of mental disorders in U.S. adults. 85% of people with BPD also meet the diagnostic criteria for another mental illness. Or just other illnesses in general, including diabetes, high blood pressure, chronic back pain, arthritis, and fibromyalgia. All things having to do with binge eating, you're going to get high blood pressure. Fibromyalgia, arthritis, and back pain can be coupled with stress or certain coping mechanisms where you can tense your muscles up because you're in a panic or having a panic attack. These conditions are associated with obesity, and it's a common side effect of the medications prescribed to treat BPD and other mental disorders. Now, they cover a variety of treatments, but here are some of the most effective ones. They include psychotherapy, medications, and hospitalization. Also called talk therapy, psychotherapy is a fundamental treatment, and it's a general approach to treating BPD. Types of psychotherapy have been found. The types of psychotherapy that have been found effective include dialectic behavior therapy. It's designed specifically to treat BPD, and it uses a skills-based approach combined with physical and meditation-like exercises to teach you how to regulate your emotions, tolerate and distress, and improve relationships. CBT, where you work with a mental health counselor or therapist to become aware of inaccurate, negative, or ineffective thinking. view challenging situations more clearly and objectively, and search for and put into practice alternative solution strategies that will help you separate realistic from delusional thinking. There is mentalization-based therapy, or MBT, is a type of talk therapy that helps you identify and separate your own thoughts and feelings from those of people around you. MBT emphasizes thinking before reacting so that you don't immediately fall back into unhealthy coping mechanisms before you become affected by a thought process that might be weighing you down. Schema-focused therapy combines therapy approaches to help you evaluate repetitive life patterns and life themes, schema, so that you can identify positive patterns and change negative ones. Transference-focused psychotherapy, also called psychodynamic psychotherapy, TFP aims to help you understand your emotions and interpersonal difficulties through the developing relationship between you and your therapist. You then apply these insights to ongoing situations. Treatments can also include medications for the short term. However, you can't cure BPD with medication, but they can help you treat the symptoms, such as the depression and impulsiveness and anxiety. These can include antidepressants and antipsychotics and anti-anxiety drugs. It would also be take certain sedatives, sleeping pills, Adderall to combat the serotonin imbalance that would cause you to fall into a delusional pattern of thinking. The medications must be appropriately prescribed by your doctor, in adequate doses, and with consistent supervision through scheduled follow-up visits. The worst thing that anyone with BPD can do is infrequently take their medication. However, it's a catch-22. If you infrequently take your medication, the side effects of doing so can actually be worse than the symptoms of the condition themselves, and it might exacerbate the symptoms. However, the condition is characterized by impulsive thinking, reactionary thinking, and quick decision-making, and a forgetfulness and a dissociated sense of your priorities. So it can be kind of hard for somebody to remember to take the medication that would allow them to not have to deal with those symptoms. However, like I said, it's a catch-22 and a vicious cycle. Then, most, if not all of the time, it might also result in hospitalization, as anyone with a psychiatric disorder will eventually, most likely, be hospitalized at some point as a course of their treatment. They may need more intense treatment in a psychiatric hospital or a clinic. It can also keep them safe from self-injury or suicidal thoughts or behaviors. Treatment can be intense and long-term, and one has the best chance for success when they consult mental health providers who have experience treating BPD.
I think it absolutely contributed to a lot of negativities that I had in school.
Mm-hmm.
Like, probably all of them. Other than, like, okay, most kids have that, like, you know, wanting to make friends, that kind of problem, which, when I was younger, I only had, like, one or two good friends, and, you know, if I lost that friend, it was kind of an awful thing. But it was always an awful thing. Like, like, depressing for months at a time. And I mean, you know, when I was in junior high, I kind of overvalued a friend who I spent every day with, and she ended up, like, you know, kind of just ditching me a little bit, but and she kind of had to do it abruptly because I was the kind of annoying person who would always be, like, calling her, because, like, where the fuck are you? Sorry.
Okay.
Where the fuck are you? We used to hang out every day and take naps together. And I mean, yeah, so, and then, you know, we stopped talking, and then instead of being like, oh, whatever, you know, she's kind of a bad friend, it's more like, what is wrong with me? Why doesn't she like me? And then it turns into anger, that she's a bad person, you know, saying a lot of bad things about her. And I mean, that was pretty bad. I mean, that gave me a couple of months of just feeling like I was, I don't know, I just valueless. I mean, I ended up becoming friends with her again, and we're very good friends now, because kids do things like that, you know.
Mm-hmm. Yeah.
But, and she, you know, we both matured. But anyway, I mean, as I got a little older, I had groups of friends, but it was always that thing, like, I wanted to fit into that group. I wanted to be a part of that group, and when I felt like nobody was paying enough attention to me, I felt worthless. And like I had to do crazy things to grab attention of people within my little groups of friends. Yeah. There are other things. I mean, I could go on and on, Sean, about how this has affected my education. Probably more towards, I would say, with the education part of things, less about like the social part of school.
Yeah.
As far as criticism, I cannot take criticism easily from like my teachers. I wanted to do the best that anybody could do. not so much thinking about myself. I was always thinking, I want to be the best. I want to be the best. I want to be the smartest. And even if I got an A, if I had some kind of, and constructive criticism written from my teacher, I would take it so deeply. I would be like, I'm crap. I can't do this. I'm terrible. I'm never going to be good at this. And that goes into work as well.
You think that delusional thinking can have an effect on your motivation to achieve academic goals?
And that, I think we can both agree, was exhibited in college when I failed that calculus course. Mm-hmm. And then the next semester, I did not go to class very often. And it got worse the next semester, which I ended up dropping out because I wasn't going to be able to pass my classes. Which, again, those failures made me feel more and more worthless, even though there are things that were under my control. Should have been under my control.
Students with a history of psychiatric disabilities can be intelligent, sensitive, creative, and interesting. However, you have to employ certain strategies in order to engage them and educate them properly so that they can move past the limitations that can manifest themselves as learning disabilities because of the disorder that they inherently are born with. These can include incorporating experimental learning activities. You have to be prepared to set behavioral expectations for all the students in your class and embrace diversity to include all people with psychiatric disabilities, of course. You're going to also address a variety of learning styles. These adaptations for students with mental illnesses require many adaptations to allow students with equal access to classes, programs, and coursework. The emphasis is on access, not outcome, and it's done by providing the student with a disability equal access to the content and activities of the course. Special Education 101. So you have to do the same thing in certain ways for people with specific psychiatric disorders. Each student with a disability is encouraged to register with the office that supports their disabilities, and the disability office also covers students with behavioral and psychiatric disorders. And the best solutions result when the instructor, student, and disability support service professional work cooperatively. Meeting as a group may facilitate problem-solving alternatives. Respecting the privacy of the student by not discussing his or her disability or accommodations with others outside of his meeting is essential. It is nobody else's business but the students and the student's IEP team and their teacher. The classroom accommodations that can be provided include preferential seating, especially near the door to allow leaving class for breaks, assigned classmate as a volunteer assistant, beverages permitted in class to combat dry mouth from the medication side effects, prearranged or frequent breaks that would allow them to get out of the class if they're feeling an attack coming on, if they need to take a walk to calm some kind of delusional pattern of thinking or that intense burst of anger that could come out of nowhere just because some girl made a certain sound. Somebody with BPD can get extremely distressed about that, and they'll interpret that as anger, which of course we know is not a logical thought process, it's a perceived thought process. There's nothing we can do about it. The only thing that you can do is if that starts to come on, you can establish a dialogue with the student early in the year before the class starts, and you can say, if you need to get out and take a walk and get some fresh air and take a breather, you're more than welcome to do so, just so that you don't cause disruptions in the class or that you don't become embarrassed with a certain behavior that you might exhibit that you can't control. Coupled with more time in order to get appropriate feedback, you can also give course materials and lectures that you do on PowerPoints on handouts or discs. You can allow them to use tape recorders so that they can get a little bit more information if they get distracted by outside stimuli. Early availability of the syllabus and textbooks if necessary so that they can kind of get a little pre-instruction, an idea of what's going to go on so that they aren't hitting the ground running or flying in blind when they're in the middle of doing what's expected of them in terms of academic work. And private feedback on academic performance as well, because they might have anxiety about criticism in a public setting or in a group setting. So if you want to give it to them privately, they might be able to handle it better so that you can establish a one-on-one dialogue. There's also accommodations for taking exams. substitute assignments in specific circumstances, advance notice of assignments, and permission to submit assignments handwritten rather than typed, written assignments in lieu of oral presentations or vice versa, and assignments completed in dramatic formats, demonstration, role play, and sculpture. Assignment assistance during hospitalization, because hospitalization is a realistic possibility for anyone with a psychiatric disorder, and extended time to complete assignments. Also, in substitution for taking an exam, a student may be able to write an academic paper. So, one accommodation that many people can make is you can substitute a paper for a test, and that solves the test-taking anxiety hands down. It also shows that somebody with a disorder has an understanding of the content knowledge, they know what was expected of them, and they can demonstrate it properly, and you take that they meet the course expectations but in a different way, and you solve the dilemma of test-taking anxiety at the same time. There are also unreasonable accommodations, and a lot of people ask where to draw the line. Well, these are the standards for where that line might be drawn. Unreasonable accommodations can include making the accommodation or having the individual involved in the activity which poses a direct threat to the health or safety of others. So, if they're in inclusive instruction, if by this point they're so advanced in their symptoms that they cannot be around others and they pose a danger, then they might have to be removed and segregated out so that they can have maybe one-on-one IEP instruction or private tutoring in a special education class. If you have to make an accommodation that means making a substantial change in an essential element of the curriculum, then it is an unreasonable accommodation. You can't change everything around just for one student, no matter how much you try to include them in the instruction. You also have a lot of other kids that you're responsible for, so you can't completely change everything just to meet the standards of one person. It's unrealistic. If you make an accommodation that would require a substantial alteration in the manner in which educational opportunities are provided, that it would become unfair to the other students, such as course objectives being altered, that's not an accommodation you want to make. And last but not least, any accommodation that would impose an undue financial or administrative burden to the institution is not right. For example, if somebody with borderline personality disorder, and this is a realistic example, does not want to leave their bed because they're anxious about getting through the day, you cannot replace their desk with a bed. That is unrealistic. They have to know that there are certain things expected of them, and despite the fact that they have a psychiatric disorder, life is a thing. And once in a while, they have to get a good kick in the butt in order to realize that it is difficult for them to separate those patterns of thinking. However, it's not impossible, and there are things within their control, and they can learn to gain more control over those patterns of thinking. But you can't meet every single one of their standards and their requirements that make them comfortable, because what can make them comfortable can also be contributing to them delving into those unhealthy coping mechanisms. It is a catch-22, and it is very difficult to interpret and deal with. However, if you anticipate it, and even as a general instructor, if you know some of the symptoms and how involved engaging you can be, there are short-term solutions to certain problems that you can administer before they even arise. The medication regimen and everything else should really be handled by the student's psychiatrist. Their therapy should be handled by the psychologist. And any adaptations that you are allowed to make would be recommended to you by the special education department or the student's IEP team.
I would guess that most people, when they first meet me, probably don't really know what's going on, but I think that, at least for me, I guess the anxiety part is pretty evident, because I'm the kind of person that's always fidgeting in a social situation with new people because I am nervous, or I'll get very loud, and that they might just assume that I'm a bit obnoxious, I'm naturally obnoxious. I don't know. Which I'm not. I'm either too quiet and they think that I'm pretentious, or I'm too obnoxious and they think that I'm an attention grabber, which I guess I sometimes am. But I don't know. I would have to ask people if they thought it was obvious when they first met me. Oh, yeah.
Yeah.
There's a lot of misconceptions. I mean, people, they don't know why I'm doing something, and often it'll be frustrating for that person.
Mm-hmm.
Even though, and they might assume, that I'm doing it for a reason that I'm not, and usually the reason I've assumed is much more negative than what's really going on.